hello, everybody. Welcome back to our second interview for Endoscopy on Air. First of all, of course, we want to remind you of June 4. That's the big worldwide event. And in preparation of that, Amrita and I have traveled to Sydney, rented a studio, and due to the corona restrictions, we can't have Michael here, so he's joining us from home. So, Amrita, we have a series of questions, and we have a very famous guest.
Yes, we're really delighted to have Michael Bourke from Sydney, Australia join us. Michael, are you here with us?
Yes, it's a great honor to be present with you.
Hi there,
not in
welcome.
person, but at least in the same city.
Welcome. Well, Thomas and I just enjoyed a very, very rapid trip over to Sydney. We're really excited to be here with you. And we just wanted to ask you a few questions about your upcoming participation in Endoscopy on Air. Really excited to see you. I think you'll be kicking off the program on June 4th. And we're just wondering, actually wanted to start a little bit on the personal side. How has the sort of pandemic been for you with the extra time off? Anything that you've gotten to do with yourself that you wouldn't have otherwise had time to do?
Well, we've been very fortunate in Australia, as you know. If we have a single case in Australia, it makes headline news. So we've had very, very few cases in the last, and all up maybe 1,600 cases in the whole of Australia during the pandemic, and less than 100 deaths, I think. So because we're an island nation, we've been able to isolate. But the great benefit for me has been that I haven't had to travel. So I took my last plane trip in February 2020, and I remember coming back from Los Angeles after a course in LA and going to the airport and watching all these people running around like insects and thinking to myself, this is not sustainable. And since then, I haven't been on an airplane, and it's been wonderful. I've found myself going to the airport at times thinking, what the hell am I doing? All this travel. So I've had lots of time with the family and been able to relax and enjoy my life more fruitfully, I think, more productive at work. Our research has been better, and I've had more time with the patients and more time with the family, and all around it's been actually a very good year.
That's great. Yeah, a lot of us have now, I think, been able to get some really positive things out of the time that we're forced to spend with loved ones and friends. So, but as you said, you're traveling less, but that doesn't make this event coming up any less sort of global and international. And wondering if you can tell us a little bit about your thoughts in participating in this Endoscopy on Air this year.
Yeah, look, it's a great honor to be involved once more. I think last year's meeting, which is, coming up to 12 months ago, was a huge success. So a great credit to Thomas and Ali and the others behind the scenes who conceived the idea and drove it to its fruition. It's certainly going to be part of endoscopy and medical education into the future, these large online meetings. And we're only just beginning, and the possibilities of how it all comes together and what can be done, it's wide open. There's a lot more that we can achieve through this type of medium of education. I think in the future, the model will probably be a little bit hybrid. We'll have people still want to meet each other, and the social interaction is very important at these medical education events, but online learning and this type of meeting, Endoscopy on Air, will have a big future. And to have some of the best units, best endoscopists in the world back to back and sort of circumnavigating the globe like it was the new year, watching fireworks here and then fireworks there and so on, is a great idea.
Great.
Well, if I listen to you, Michael, you said you had more time for social contacts, and when I speak to colleagues or congress organizers, they always stress how people want to get to those meetings, and have the social aspect. So does it mean that we have put too much of our social contacts into business, and we should take care more of friends and put the online or put the learning into the online area?
That's a complex question. I think we can also have very good friendships amongst our colleagues, and because we're all in a similar field, we have similar problems, similar burdens, similar issues that we need to converse face to face to resolve and share support from one another. And there's no doubt that interacting with your colleagues and discussing difficult cases or difficult issues, a lot of the issues that we have or the troubles that we have at work or with our profession relate not necessarily to patients. They can be that, but also professional issues and administrative issues and so on. So the face-to-face interaction with colleagues, I think, is very, very important. So going forward, I think the model for education will be hybrid. It will also include things like Endoscopy On Air. That aspect will expand substantially, but there'll still be live meetings with personal interaction for sure.
But how, in your mind, how would you envision a hybrid meeting? Is it just a smaller meeting with a transmission to everywhere, and you get everybody into your endoscopy room, and every meeting has a worldwide faculty and no travel?
No, perhaps you have regional people coming to your center or to an auditorium, as is done with, Endo Club Nord or with CEAS, Sydney International Endoscopy Symposium. We mainly have people from Australia and New Zealand, a few from Southeast Asia, but Australia is an expensive nation for people who aren't living in it. And then you can broadcast the cases and the work around the world in a similar platform to Endoscopy On Air, and perhaps link up with other sites at various times. I mean, there's a lot that can be achieved in a hybrid model, I'm sure.
So, Michael, I was wondering if we can talk a little bit about the exciting endoscopy that comes out of your unit. Year after year, you're introducing us to new techniques and really changing, I think, the way we practice endoscopy, colonoscopy, polypectomies. Can you give us a little preview now that you've had all this time to sort of develop new techniques, and you said your research is flourishing? What's on the horizon coming out of your unit, and maybe what we can expect to see perhaps during Endoscopy On Air, or if not ready to share?
No, I can share some things. Well, what happens on Endoscopy On Air is I don't want to offend Thomas, but it's scripted by Thomas. So he tells me what cases I'm supposed to do, and that's what I do. We're very fortunate to have a huge referral base for tissue resection. So we have, a lot of Barrett's early cancer, a lot of, of course, all the polyps in the colon. And then, we have a lot of early gastric cancer, and we have all the lesions in the duodenum and so on. And then, biliary disease, etc. So we're very fortunate to have all those cases coming to us. And at least I think what's going to happen in the future is endoscopy is going to have an increasingly important role in the management of early neoplasia, early cancer in the GI tract where the surgical options are poor. So I think that, we're going to see more rectal ESD with adjuvant therapy. Adjuvant radiotherapy for high-risk disease. Obviously not T2 disease, but, advanced T1 with deep SM or otherwise adverse features on histology, and definitely in the esophagus. I think esophagectomy is gradually going to die. So we do more and more aggressive resections in the esophagus. We remove, every Tuesday we do 2 cancers, by ESD and so on. So that's some of the stuff we're working on. In terms of the polyps, we've almost got that sorted, I reckon, by EMR with snare tip, no recurrence, bleeding, we know, clipping, there's a few other things to be resolved, but a lot of the work in the big polyp area, we can consolidate things and fine tune on things, but it's become very safe and very effective. Maybe we need to get better at teaching it to people. We need to teach people simpler ways of imaging lesions. I'm always talking about looking for homogeneity versus heterogeneity and demarcated areas and so on. So they're just some ideas, but yeah.
That's really
I don't want to
exciting.
blather too much.
No, that's very exciting. We're looking forward to that. Thomas?
Well, Michael, let's speak about evidence a little bit. I remember that session in Düsseldorf when the two of us, it was about the old story, EMR versus ESD. And there were two guys in the audience really attacking us on an emotional basis. How could you withhold ESD from a young patient, and that's not ethical and so on? You had a hard time defending the evidence. So
I did.
What's your vision? I mean, we hear many lectures which just cite guidelines, and we have meta-analysis, and so where is that going?
Yeah, well, I think we have to remember that we mustn't be we have to be dispassionate about how we discuss these things, and people always say, do you believe in this? It's not a matter of belief. It's just a matter of, reviewing the evidence, as you say, and deciding, what that tells us. Well, we know that most of the lesions in the colon are benign, and all the data, masses of data now show that they're very effectively managed by EMR by and large. So if we were to advocate for ESD for every lesion, that would be illogical. We have to choose. In medicine, we're trying to minimize invasiveness, and we're trying to choose the safest, most effective, most efficient means and least expensive means of treating the pathology. And that means we mustn't choose a more expensive, resource intensive, time consuming technique when we have another technique that works very well, because there's also the concept of opportunity cost. Patients miss out on having the procedures they need because you're spending 3 hours on something that should have taken 30 minutes. And now we know also with imaging that it's getting increasingly accurate, and we can structure it based on morphology, flat versus nodular. So risk of covert disease versus overt disease. And I like to use the Italian food analogy. If you're looking at a flat lesion, you consider it like a pizza. You can always tell what's in a pizza. But if it's a nodular lesion, well, it's a calzone. You can't tell what's inside necessarily. So then you have to make some decisions based on that. So in the left colon and rectum, when we see significant nodular disease or mixed nodular or bulky disease, then we do ESD. But elsewhere, for flat lesions, if we don't see any concern for cancer, it's almost universally not present. The risk of missing it, if we do have a paper on this, the risk of missing it is around 6 in 1,000 cases for flat lesions. It's very low.
I like this example. I think we have to cut the sequence out and show it on YouTube all the time with the Italian pizza and the column EMR. Yet, Michael, there's a huge push from the Far East, supported by industry, to develop sophisticated devices for en bloc, and there's this en bloc movement. So what do you tell people? Do you think that's a lost battle because it's so sexy, and or will people get tired after the first 3 cases and get back to EMR?
I think the people who want to embrace ESD for every lesion don't have enough cases. Like, we just couldn't do that. They might have 1 case a week. We have like 10 a week and a waiting list. So, and I don't think we have no data to show that the patients are better off. In fact, we know they're not better off. And we have now, in the ACE study, which is, the Australian Colonic Endoscopic Resection Study, we have 5,000 cases of polyps 20 millimeter or greater. And we have all the data that tells us, we can answer all the questions from much of that data. So there might be a move to embrace ESD, but I'm very pro ESD for things that need it. That's for sure. But a flat granular lesion in the right colon has a risk of cancer of about 0.6%. That's all comers. So if you look carefully, you see no cancer, there never is cancer. So I don't see why that should be done by ESD.
Well, maybe we can ask Amrita how the situation in the States is, because it seems to be a Far East phenomenon, and that's readily taken up by some European centers. So how's the US going with ESD, if we are in that discussion?
Well, I think right now, the issue is how do we disseminate the training, given that we don't have a similar system as they do in Asia in terms of volume of patients, as well as volume of preceptors or ability, especially with COVID, to be able to travel to courses, hands-on courses, and be able to work with preceptors. So I think that might be one of the limitations. And I think Michael's right. In addition, we really do have to, while we want to adopt new techniques, always remain sort of thinking about the indications and the science behind it. What are we really doing in terms of preventing recurrences? And actually, Michael, I wanted to ask you, AI is the big topic these days, and you were talking about better ways to identify and maybe help distinguish early or quickly which polyp should be treated with EMR versus ESD. What are your thoughts on the emerging role of AI? I know we have some new data coming out. It's going to be talked about.
Yeah, that's a very good question. I think it definitely will have a role. We've been participating in research along those lines, and we've made an enormous number of videos of high grade versus early cancer versus nothing in various morphologies. So there will probably be some sort of AI composite risk score. And if you can teach people to just look at the polyp with the scope and spend the appropriate amount of time, which probably has to be driven by an algorithm as well, like 15 seconds doing this, 10 seconds doing that, and so on, overview, close up of the nodule, and so on. You'll probably ultimately come up with some sort of risk assessment for covert cancer or indeed overt cancer and probability and so forth. So going down the line, it's going to be there for us to help, I'm sure. It's a ways off yet.
That's great. And I know we'll be featuring some of that and during Endoscopy On Air. So looking forward to see where we are going with that.
Yeah, just on the recurrence thing, so we just published that paper in Gastro. It's online. So it's a multi-center international study, 1,000 cases, over 1,000. And recurrence after snare tip was less than 2%. So the randomized trial, the recurrence rate was 5% because we didn't realize how safe it is. But if you're very aggressive with it, you can almost, in my own practice, I never see recurrence, never, ever. So,
I guess the key to that really is then disseminating those techniques and making sure that we're teaching polypectomy kind of with updated techniques that allow for that data to really stay consistent. And I think programs like this one, are really important for that. Not only to see it come out of your lab, but hopefully to see it practiced globally, and techniques like it. And I think that's one of the benefits of Endoscopy On Air is really to see, are we spreading these new methods across the globe?
Yeah. And in fact, most of the new methods, like people are always reaching for technology to solve the problem, but often the answer is in front of us and it's just good technique. It's as simple as that. It's just high quality endoscopy. And people always say, well, I need that device or this device. But, a lot of the time, I think, honestly, often it's just good technique. There were 16 endoscopists in that study and they all had very low recurrence rates. It's eminently achievable. On the other side of the coin, I would say in terms of learning ESD in the West, the easiest place to learn is in the stomach. And, there just aren't the cases, at least outside of the referral centers. So I still think that it needs to remain as a specialized technique within referral centers so that the technology and the technique can be applied appropriately and safely.
Yeah, and those are areas of innovation where, you know, like we do know that industry is interested in helping develop tools that can make, for example, ESD in the colon when needed easier and safer, like traction devices and whatnot. Maybe even working with different types of energy. So it'll be exciting to see how all that rolls out, but also where it actually fits into our whole toolbox.
Yeah. And we mustn't forget now the cold revolution, right? So we're halfway through a randomized trial of hot versus cold for flat laterally spreading lesions. And cold will win. Cold will win for flat lesions. There it is. The recurrence rate will be low because you can excise as much as you want. Take the whole circumference if you want to. And there's absolutely no risk to the patient. And even if there's a little recurrence, you know, it's easily treated in follow-up. So no risk of perforation, no bleeding, nothing.
So simpler is better.
Well, for a lot of things, for sure. Yeah, it doesn't make the companies happy, but that's the truth of it.
But Michael, at the end of the medical questions, I have one concerning quality control. You have got around the world quite a bit, seen different systems. So should quality control be free market and patients will find out who's the best from whatever, or is that a central task of I don't know, insurances, government, whatever? So what's your recipe?
Oh, yeah, that's a difficult question. I mean, I think we have to. There's of course a minimum standard. At least in Australia, we have minimum requirements that everyone has to achieve to be practicing colonoscopy, for example. But quality can suffer, and the patients are really not in a good position to make a decision about who is likely to serve them best. It's challenging, but then again, many professions would resist central regulation. But on the other hand, if you want to improve quality, you have to establish some minimum standards and get people to embrace them, and then slowly lift the bar. That probably doesn't answer
Australian patients, the argument, at least in our country, is always that it cannot be centralized because the patient only want to travel 5 kilometers, and there has to be everywhere the facilities for this and that. I mean, you are less
I think for sure
country.
You cannot decentralize. The complex interventions cannot be decentralized too much, because then the expertise evaporates because no one has the volume, and the outcomes deteriorate. We know that from as far back as those New England Journal publications on surgical volume and morbidity and mortality relating to esophagectomy, pancreatectomy, even colectomy, and so on. So I've forgotten the name of the first author just now, but from 2001, 2002, I used to use them in talks all the time. So you do need volume to drive excellence, and you need colleagues, and you need a multidisciplinary approach.
Michael, maybe we can go back to or end on a personal note. Any new hobbies that you picked up during this time, or I know wine tasting is something that you were really into. How's that going?
Well, like yourself. No, not really. I wish I could say that I exercise a lot, so swimming and so on. So I coach my son's water polo team. So I've been putting much more effort into the coaching and so on. So that's been a good thing. But I haven't, for instance, learned a musical instrument nor developed any other great passion. I love reading about everything broadly, so I've had more time to do that. Yeah.
That's great.
And in the nice, we have behind our studio is the nice opera house. Of course, it's probably closed, but have you been there?
I know it's open. Everything is open in Australia now. So it's almost at full capacity because We have a quarantine system and so on. So I've been to the Opera House to see many events. Yeah, many times. It's a wonderful experience. Yeah.
That's great. Well, we're looking to hopefully join you one day soon there. But
Yes.
in the meantime, we'll see you for the program, and really excited about that and joining you and the rest of our colleagues around the world.
Yeah, we're all excited at Westmead and here in Sydney. So we're looking forward to the event. It's going to be a lot of fun as usual.
Thanks very much, Michael. Thank you.
Yeah, my pleasure. Thank you.
We're very pleased to have you here.
Bye.
So goodbye
Bye.
to everybody, and don't forget Endoscopy on Air, June 4.
Bye, everyone.